What's up, everyone? Floating Vent Guy is back. So we're back for episode 2 of the podcast, the Peak Inspiratory podcast, talking about my favorite autopeep. And you'll probably recognize these from Instagram handle. And not that I want to sort of like repeat content, but I think, well, number one, I spent a lot of time on them, honestly. And number two, I think they're actually pretty good. So we'll go through them because maybe it'll be more helpful to sort of hear it a few times. So the physiology of autopeep. So remember, this gets a little bit into the weeds, and I don't want to do that too much. However, I think it's important to talk about a few things. So what governs autopeep, or what is sort of like the underlying physiology? So the underlying physiology is essentially the equation of natural decay. So the equation of natural decay is based on ultimately the volume, in this case, that we instill, and then the rate of that volume dissipating is directly proportional to both the resistance and the compliance. So for this purpose, I is the volume remaining. O, or V naught, I guess, is what we added. No matter if we have the correct numbers, there's probably some volume that's going to be too much. Even if we have a perfect expiratory time, there's probably some volume that's going to be too much for the lung to handle. So if we made the volume like 2,000 milliliters, that it's sort of irrelevant how long we give the lung to empty. It might be too much. But so E is a constant essentially. T is the total amount of time, and then the R times C, which is our beloved tau. So is knowing this terribly important on the day to day? Certainly not. However, I think it is important to understand the underlying physiology. Another way that tau, or the time constant, is represented is by the resistance times the compliance. So remember that the units for resistance are centimeters of water per liters per second, and then compliance is liters per centimeters of water. So if we multiply these, we would have seconds left over. So essentially, multiplying these two components gives you the time constant. So if you by somehow have the resistance and the compliance of the lung, you can easily get the time constant. So we say that we need about 3 time constants to empty completely. Now, it's going to be the first maiden voyage in drawing. So let's see how this goes. So remember, this 37 is just a percent, meaning the rate of volume decay isn't a absolute number, but it's a percentage. So 37, 14, and then ultimately 5. So that's how much is left. So in a volume time curve, which this essentially represents the volume time curve, you can pick sort of any point on here and just get 37% of whatever number you randomly pick, and then do the math for that sort of point A to point B. So if I, picked here and then I picked here, I would just get whatever 37% of this number is, and then get the time from it took me to get from point A to point B. And then if I subtract those two, that gives me the time it took, and then i.e. the time constant. So multiplied by 3. This is visually represented on this figure, the B figure, that you can look on a mechanical ventilator and you can certainly see if it's taking a long time for the volume to leave, then the time constant is probably going to be longer. But if that air is coming out quickly and getting back to the baseline fast, then it's going to be a short time constant. So just by sort of eyeballing this, you can make some inferences on if the time constant is normal or abnormal, number one. Number two is that by eyeballing this, you can also recognize if there's autopeep, because remember, if we get to say, let's say here, and then another breath is fired, remember, sort of all of this volume, and I'll sort of trying to change the color, all of this volume, all this like purple volume right here didn't come out. So it's left over, which essentially is kind of the visual representation of autopeep. So hopefully that's helpful. Now, how do we get the time constant? So I mentioned one, which is, I really mentioned two, I guess. The first thing you can do is get the 2 points on the graph, and that gets a little bit more difficult because it depends on the ventilator and how you record the screens and that kind of thing. If you had the resistance and the compliance, you can do that. You can multiply the two. There is a sort of volume over flow method that's a little bit more complex and not user friendly that I'll sort of avoid. And then lastly, some of the ventilators actually do it for you, which is nice. So for example, the Servo McKay, the Servo U, if you do an inspiratory hold and expiratory hold, if the patient's passive or paralyzed, as sort of everything in this is, it will calculate a time constant for you. And just sort of off my anecdotal checking, it's pretty close and certainly good enough to use in, certainly a pinch. So I generally get the time constant if I'm worried about autopeep, and I set the ventilator up very specifically. Does everyone do that? No. Is it sort of necessary to do that? Probably not, although I think it's good practice personally myself. And I do it and I think it helps and allows me to control the situation much tighter. So, a lot of discussion about I to E time, or really I time in this situation. So, this is a graph of if you decrease the I time by some number, some sort of nominal number. So, if you look at the bottom table. So if you look at the bottom table, so the flow is sort of doubling 30, 60, 90, 120. And like 120 is pretty tremendous. So it's pretty fast. Sure, you're going to go from I time of 1 second down to 0.25 seconds. But remember, what are you going to suffer? You're going to suffer the peak airway pressure, because to get that volume in faster, you're going to need to increase the flow, which you're doing. But remember, the first part of the peak airway pressure is made up of the flow and the volume. So your peak is going to go absolutely through the roof. And then what are you going to be left with? So you already have a high peak because of a resistance issue. Now we're going to be increasing the peak even more because it's going to be a flow issue. If the patient isn't paralyzed, I can't imagine them taking a breath with 0.25 seconds is comfortable at all. So there's probably going to be a lot of dyssynchrony. So sometimes I try to save some time on the I time, sort of on the back end if I'm really stuck. So I generally make my I time about 1 second because the math is easier. Number one. Number two, however, if I'm still a little bit stuck, I will creep the I time down to maybe 0.8, knowing that the peak airway pressure is going to be higher, but I'm just trying to sort of scrounge up every bit of time that I can. Some take the approach of decreasing the total volume. Tobin highlights in a study that so decreasing the total volume is a fine strategy, I guess, with the caveat that the patient should be paralyzed probably, because even if let's say you cut the total volume in half just because the math is easier. So if you went from a total volume of like what you want, so let's say you cut the total volume in half. You went from, I don't know, like 450, so maybe not half, but 450 to like 250 or 300, let's say. 300, because you're trying to sort of influence that first part of that equation that I talked about, which is what volume do you start with? If you do that sort of willy-nilly and the patient isn't paralyzed, then the patient is going to breathe faster to sort of achieve that minimum ventilation that they had before. So in some ways, you're going to make it worse probably, because they might go from breathing 20, and if you cut it in half, it might just sort of go to 40, which would make things a lot worse. You would have a lot more autopeep. So just influencing the volume isn't sort of as great. Although if you have more control over the situation and if the patient's paralyzed, then you might be able to sort of take the volume down while knowing that you're going to suffer some minute ventilation issues, but that could be another thing that kind of saves you. So in summary, autopeep is clinically significant, obviously in multiple ways: barotrauma, hemodynamic collapse, dysynchrony. The best ways to fix it immediately are decreasing the breath-to-breath time, which will then increase your expiratory time if you leave your inspiratory time the same, and by fixing the underlying condition if you can. So if it's asthma, treating the asthma. If it's COPD and you think there's some sort of reversibility to it, treating the COPD reversibility. So this was our second episode for this video cast series, I guess is what you'll call it. So please leave comments, thoughts, complaints, issues to let me know how this is going and if it's something that's worthwhile. And I appreciate it.